In my daily practice, I perform multiple regional anesthesia techniques. Some of those are individual nerve blocks, such as interscalene blocks, femoral nerve blocks, depending on the actual list that I'm doing. I usually perform quite a bit of upper limb, shoulder and hand trauma surgery, anesthesia, and also foot and ankle surgery. I thought that this device would initially just be a gimmick and that it would not actually have any advantage in my clinical practice. I then eventually unwrapped the device, realized that I could, without actually reading the instructions, put everything together. It was so simple to use and so simple to actually put together. I then started injecting for the first time. It was a little bit interesting because I was a little bit concerned about having to concentrate on a foot pedal and your hand-eye coordination. In the past you've had assistants to do that, but actually within a minute or two you realize that it was quite simple and easy. Also the rate of injection from the SAFIRA device is so nice and slow that and probably more appropriate, that the flow of local anesthetic is at a nice consistent rate. The foot pedal worked absolutely fine for me, and the injection rate was so nice and just the appropriate sort of rate that you could still see hydrodissection. You can see the local anesthetic coming out of the needle tip, but not that fast that you actually then end up injecting too much local anesthetic. In the UK, we use assistants to normally inject for us. And in my hospital, and I'm sure this is the same situation in other hospitals, the rate of assistants seems to be changing all the time. There's such a turnover of staff. So actually to have an experienced assistant and that actually has that experience about how fast to inject, at what pressure to inject, that is becoming more and more difficult. Even those people who think they have experience, it has been shown in studies that the injection pressure is quite variable for them anyway. So I think that's the first bit, that you can have inexperienced people, and often you do a block and you ask for just 1 or 2 mils of local anesthetic, and they think they should deliver the local anesthetic as quickly as possible, and before you know it, the total volume has already gone in. Pressure threshold for me was important, because often when you do different types of blocks, you put the needle up to a fascial plane, and nerves are always running within fascial plane, so you just have to get right up against the fascial plane or through a fascial plane to then deliver the local anesthetic. Occasionally, without SAFIRA, you would be tempted to actually force the local anesthetic into a particular area, and possibly that is potentially unsafe. SAFIRA actually, to me, demonstrated when the needle hub was either up against a fascial plane or you didn't actually clearly have an injection path. So, and then secondly, obviously, took the guessing of the pressure out of the system. It's a very, very clear indicator. There's a red light that comes on, it stops injecting, and you have to then aspirate to reset the device, which again is very easy because it's all done with the foot pedal, so you don't really have to change too much. But I think having a consistent pressure is essential and really, really works well. In regional anesthesia, one of the major concerns is a nerve injury, and I've always been a proponent of using hydrodissection. In other words, you inject, you create a potential space, and then move your needle into that space. this has been shown to reduce the potential and for needle nerve contact, and this is exactly when nerve injury may occur. I think it's very, very unlikely that you'll be able to introduce a needle into a nerve if there's local anesthetic coming out of the needle tip. This is one technique that I've always liked to do and that I teach. In the past, with hydrodissection technique, you might use a bit of extra volume because, again, your assistant might be inconsistent in how quickly they inject. And this is maybe one of the biggest advantages, is that the SAFIRA pressure and the injection rate is very well controlled. You then actually end up using a lot less local anesthetic, and you can still manipulate the needle around the nerve. And on the local anesthetic deposition around the nerve, giving you the perfect block. I was surprised in the first, I'd say 10 blocks that I did, that I probably used about a third less local anesthetic than I would have used, because normally you would, when you look for block success, I look at how the local anesthetic is actually surrounding the nerve. And with an assistant injecting, you would normally get 10 mils or 20 mils. With the SAFIRA system, often, as I say, a third less, and you're thinking, well, where should I put the rest of the local anesthetic? I've achieved my goal, and the nerve was nicely surrounded. So from that point of view, that was a pleasant surprise. And obviously, in fascial pain blocks, especially if you have to do multiple blocks, local anesthetic toxicity might eventually come into it. So I think it's important that the lowest volume is used for achieving block success. With the assistants having less and less experience, and the actual anaesthetist having more and more control, I feel you can manipulate and achieve greater success in regional anesthesia. I know there's a lot of anaesthetists that actually prefer to inject for themselves. They have developed all sorts of techniques, the Jedi technique, a one-handed technique, and I've got big enough hands, and I can manage those techniques, and I've done those techniques quite a few times. But occasionally, you lose a little bit of needle control, because you are injecting at the same time. And usually, you'll have to use a 10 ml syringe instead of a 20 ml syringe to do this, to achieve this. Because the injection and the aspiration is on a foot pedal, which is very, very easy to use, nice and simple, 2 colors, very easy to achieve. And as I said, the learning curve by using the foot pedal was rather straightforward and quick. You have complete control. Your ODP or your assistant can then actually maybe pay attention to the patient, help you with other bits and pieces around, and it frees up their time. So I feel a lot of anaesthetists are actually wanting to make regional anesthesia a single person technique, and SAFIRA absolutely helps you achieve that. I think every regional anaesthetist that's serious about safety in regional anesthesia should really consider using SAFIRA or an injection pressure technique that monitors not just the injection pressure, but also the way that you deliver local anesthetic. What SAFIRA has made me realize is that for many, many years, we've been injecting local anesthetic maybe just too fast around the nerve. And if you inject at a nice slow pace, you can actually achieve a successful block, a successful spread of local anesthetic around the nerve without using that massive or a big volume. It does give the anaesthetist complete control as well, and I think it takes the guesswork out of whether you are actually injecting with a high pressure and low pressure. I think from a volume point of view, from a nerve safety point of view, and from a single-handed complete control device, SAFIRA helps you in all of those aspects, and I can't see any disadvantages to this device at present. It is just a very nice, smooth device. It is small enough that you can actually place it anywhere around the patient. So from that point of view, you can also then changing the syringes is extremely easy, and that can be, the syringes actually comes packaged in a sterile form, so you can actually click them in and out quite easily. What surprised me was the simplicity. And because it looked simple, I didn't think it would work so well, and then it worked so well, which was quite surprising. So I think it was the combination of really being effective, giving you control. The other bit was probably the foot pedal. You thought, well, actually, for the first time, you felt like a ophthalmic surgeon, because they often use foot pedals and things like that, and we normally just use our hands. But the foot pedal was quite easy to use, and I think maybe in the first block, you thought, well, actually, I just need to rearrange things. But the learning curve with that foot pedal was really quick and steep, and you probably I had to take my shoes off, and because you could actually feel the foot pedal a little bit better when you just had your socks on, which meant I had to wear better socks as well. So anyway, so wear good socks, but you can feel the foot pedal, and it's really a simple, easy device to use.